Good morning, good afternoon, good evening. Welcome to another WSO webinar. My name is Alina Schwarz. I'm the Executive Manager of the World Stroke Academy, the education platform of the WSO. And our aim is to provide stroke education to health professionals worldwide. So we're really happy to host this educational activity for the WSO today. We'll hear about the topic management of stroke with both atherosclerosis and AF mechanisms. A highly relevant clinical topic, and we are very happy to have two excellent panelists with us today, Professor Chimowitz and Professor Chaturvedi. And joining us today is also Dr. Yi Liu from the WSO Research Committee, who will now introduce the speakers, and she will also moderate the Q&A session after the presentations. So over to you, Yi.
Thank you, Alina. Hello, everyone. Welcome to join our today's webinar. My name is Yi Liu, a stroke neurologist from Shanghai Huashan Hospital in China. Now let me introduce our first speaker. Professor Seemant Chaturvedi is the Stuart J. Greenbaum Professor of Stroke Neurology at the University of Maryland School of Medicine. He is also Stroke Program Director at the University of Maryland Medical System. His talk will focus on the management of atrial fibrillation and carotid stenosis. Please.
Thank you, Yi, and I hope everybody can see my slides okay. And I'd like to thank the World Stroke Organization and the World Stroke Academy for inviting me to participate in this webinar. Dr. Chimowitz and I have been colleagues for many years, so I look forward to his thoughts on this challenging group of patients. And so I'm going to discuss several aspects of management of atrial fibrillation and coexisting carotid stenosis. And yeah, these are my disclosures. Now, we should recognize at the beginning that both atherosclerotic disease and AFib have several risk factors in common. And these include hypertension, diabetes, increasing age, also obstructive sleep apnea, and obesity. There are probably others in terms of genetic risk factors which could overlap and some other lifestyle factors, but these are several of the key ones which have very high prevalence in the community. And these are all crystallized in the CHADS-VAS score, which many clinicians are familiar with and which we use almost on a daily basis. And so you can see that in the CHADS-VAS score, we have several of the factors that I alluded to, including hypertension, advanced age, diabetes, atherosclerotic vascular disease, and other BEDS, such as peripheral artery disease. And so these can help not only with risk stratification of patients with atrial fibrillation, but they can also help to some extent in predicting which patients are going to have future atrial fibrillation. So given the overlap in these risk factors, it's not surprising that carotid stenosis and AFib can coexist. And despite the overlap, we should also recognize that atrial fibrillation patients have been excluded from virtually all the major carotid stenosis trials in the past. If we look at some of our landmark trials like NACIT, ACAS, CREST, CREST-2, all of these studies have excluded patients with atrial fibrillation. And so therefore, if you want to look at the outcomes of patients with coexisting carotid stenosis and AFib, in many cases, you'll have to look beyond the randomized trials into other data sources. Now, the coexistence of both conditions can create challenges in the diagnosis and management. And so this is a few points that I'll review, including what is the effect of carotid stenosis on the future stroke rate in patients with AF? What is the risk of development of AF in patients with carotid stenosis? And then is there any difference in the results of carotid revascularization procedures when you have concomitant AF? Now, in terms of the first of these points, the impact of carotid stenosis on the stroke risk of patients with atrial fibrillation. This is a paper from Finland where they did a multi-center registry of patients with TIA or stroke along with atrial fibrillation. And you can see in the title that concomitant carotid artery stenosis doubled the future risk of stroke. And so if we look in more detail at this registry, it was a multi-center registry in patients with stroke and TIA plus evidence of AF. And you can see that about 1/5 of the patients had at least 50% carotid stenosis. And so that suggests that this is something pretty common. And as I said, not that surprising when you consider the shared overlap of risk factors. Among the patients who did have carotid stenosis, they had a higher CHA2DS2-VASc score. And then they followed these patients for about a 3.5-year period. And you can see that carotid stenosis was an independent predictor of subsequent stroke. These patients had about a 21% risk of stroke compared to 13% in patients without carotid stenosis. These figures are a little bit higher than many of you may expect, but we should also realize that this registry is several years old and maybe didn't include some of the elements of intensive medical therapy that hopefully all of us are using these days. And not only was carotid stenosis an independent predictor of stroke risk, but you can see that for 30-day mortality, patients with carotid stenosis had a higher 30-day mortality of about 8% compared to 2%. And this graphically shows the finding that I mentioned before, that patients with carotid stenosis had lower degree of freedom from recurrent stroke compared to patients without carotid stenosis. Now, what if we look at the other side of the coin? Suppose we have patients with carotid atherosclerosis and we follow them, and what is their future risk of developing AFib? And so this was a study, a population-based study from Northern Italy, where they looked at patients with varying degrees of carotid plaque. And this was a long-running epidemiologic study with 20 years of follow-up. And you can see that in the Bruneck study, at the entry, they had about 900 participants with a mean age of 58 years, and then up to 20 years of follow-up. And patients had carotid ultrasound at several time points during the study. And at the time of enrollment, 41% had some evidence of carotid atherosclerosis. And the majority of these patients had plaques. These were not patients with 50 or 70 or 80% stenosis, but more in terms of evidence of early stage carotid plaques. But despite having the early stage disease, you can see that during the follow-up, 13% developed AFib. And so who were the participants who later developed AFib? So not surprisingly, they were older and they had a higher rate of hypertension and heart failure, as well as higher systolic blood pressure at entry. And an interesting finding in the study is that when they longitudinally followed the patients, you can see that patients with both AF and atherosclerosis had a higher death rate than patients with either alone. And this is the figure from the paper showing that compared to a reference group of patients without either condition, patients with AF and atherosclerosis had a higher hazard ratio for future death. And then this was highest in the group with combined atherosclerosis plus AF. Now, in terms of the management issues, one of the key management issues we have is trying to decide whether the stroke was due to carotid stenosis or the stroke was due to AF. And so how can you tease that out? And so there are several aspects which could be helpful. And this is a real life patient that I saw about 6 months ago. And he's a 64-year-old male with a history of AF, hypertension, heavy smoking, and lung disease. He presented to our hospital with left hemiparesis. He received alteplase initially, and then subsequent imaging showed 90% right ICA stenosis and total occlusion on the left side. He had been on warfarin previously, but this had been held due to upcoming epidural injections. And so the clinician might ask themselves, is the right carotid stenosis the source of the stroke, or is atrial fibrillation? And there are a couple of ways that you can try to address this, and maybe we can discuss this further in the question and answer portion. But one thing which can be useful is to look at the imaging pattern of the infarcts. And I don't know how well this is projecting, but you can see that in the white matter on the right side, superiorly, he has evidence of a few areas of increased diffusion weighted intensity, which are sort of lined up in a vertical pattern. And so this appears to be in a watershed pattern. And so because of the watershed distribution of the infarcts, we felt that it was most likely in his case that it was the carotid stenosis which was the culprit instead of the atrial fibrillation. So is the presence, and so once you decide that carotid stenosis is the culprit, and if you plan to do either endarterectomy or stenting, does presence of AFib portend a higher risk of complications? And then the other questions that you'll encounter is how to manage the patient peri-procedurally in terms of antithrombotic therapy, and what about the long-term antithrombotic management? So in terms of the impact of atrial fibrillation on outcomes of carotid revascularization procedures, this has been analyzed in a large data set using in the United States with the National Inpatient Sample. And so here they looked at over 600,000 individuals who underwent endarterectomy or stenting, and they found that about 10% of the patients had evidence of atrial fibrillation. And as I mentioned, this 10% is not trivial. And so you can see that about 60,000 of the patients had atrial fibrillation. And despite it being present in 10%, these patients are virtually always excluded from carotid stenosis trials. And the investigators in this paper, they looked at several outcomes, including stroke alone, cardiac complications, and then a composite endpoint of stroke, cardiac complications, and mortality. And this composite endpoint was increased in both the patients who underwent endarterectomy as well as those who underwent stenting. Here you can see that the results in patients undergoing stenting along with endarterectomy. Interestingly, post-procedural stroke was not increased in the stenting patients, but it was increased in the patients undergoing endarterectomy. And then you can see that the other endpoints of the study were increased in both groups with a trend for higher values in the endarterectomy group compared to the stenting sample. Now, what about the timing of the carotid revascularization procedure? So one clinical pragmatic tool that I've used in recent years has been the 1-3-14-28 rule. And so this says that for a patient with TIA, you want to operate quickly, preferably within 1 day. For a mild stroke, we try to operate within 3 days. For a moderate stroke, within 14 days. And then for a more severe stroke, we reevaluate the patient at 28 days to see has there been any clinical neurologic improvement, and is revascularization really needed. If their patient still has global aphasia or severe hemiplegia at 28 days, then there may not be that much value in doing the revascularization procedure. So in terms, getting back to this 64-year-old patient, peri-procedurally, we placed him on aspirin plus clopidogrel, and then using this clinical decision tool, he underwent right and CEA 4 days post-stroke. Long-term, once he recovered from the operation, and once the surgeon was satisfied that there were no risk of incision site bleeding, then he was placed on a DOAC plus aspirin for long-term management. Interestingly, I just had a video appointment with him yesterday, and he's doing well 6 months post-stroke, unfortunately still smoking. And so that's something that he needs to work on for long-term health. So in terms of the long-term management of coexisting AFib and carotid stenosis, there are several factors we should consider. What is going to be the optimal antithrombotic therapy? And I think Dr. Chimowitz will discuss this in greater detail. What about the effects of risk factor modification? And given the fact that patients with coexistent AFib and carotid stenosis have a higher death rate and a higher stroke rate, maybe we should move beyond intensive risk factor treatment to super intensive risk factor treatment. Also, are there any conditions that we should screen for? I mentioned that there are some conditions which are predisposing factors for both AFib and carotid stenosis. And so in the appropriate patient, it might make sense to test for sleep apnea. And also in terms of lifestyle management, weight loss has been associated with decreased AF burden. And so this provides some impetus to institute lifestyle management, although this is not always easy. In terms of moving beyond our current targets, these are some fairly new recommendations from the European Society of Cardiology and European Atherosclerosis Society. And so they comment that in patients who are at very high risk of future vascular events, we should consider an LDL of less than 55 milligrams per deciliter or less than 1.4 millimoles. And so many clinicians use less than 70 for patients with stroke or TIA, but given for patients with a combined AFib and stroke, maybe we should be extra aggressive and target less than 55 as the future long-term target. Now, with regard to antithrombotic therapy, we don't have a lot of high quality data. There is a fair amount of data from cardiology studies. And cardiology studies, the common scenario is the patient who has had a stent due to acute coronary syndrome along with coexisting AFib. And so there have been several cardiology studies which have randomized patients to various antithrombotic combinations. You could say that the trend in these recent cardiology studies has been to favor the combination of a DOAC plus clopidogrel. And so in general, I try to avoid triple therapy. So triple therapy refers to aspirin, clopidogrel, plus an anticoagulant. I try to avoid that if possible due to numerous studies showing a high bleeding risk with triple therapy. And so as in the patient that I illustrated, we selected DOAC plus clopidogrel for him as for long-term management. So in terms of take-home messages, we can see that AFib is present in about 10 to 15% of patients with moderate to severe atherosclerosis. Despite this, patients with AFib have been excluded from most carotid stenosis trials, including the landmark trials that everyone is familiar with. Data suggests that in patients with AFib who undergo CEA, they have a higher peri-procedural risk of stroke and death. Patients with coexisting AFib and carotid stenosis in general tend to have higher stroke rates and higher mortality. And given the fact that their outlook is worse, I would recommend that they have highly intensive medical therapy, maybe even beyond some of our current conventional targets, and that these patients do pose a challenge in terms of peri-procedural as well as long-term antithrombotic therapy. In terms of future directions, I think we can, based on the material that I presented, we could envision some future research efforts, including looking at a risk factor modification in these patients, investigation of lifestyle changes, and such as weight loss and regular physical activity on vascular event rates, and then possibly randomized trials of different antithrombotic strategies in patients with coexisting AFib and carotid atherosclerosis. And this is just a photo of our medical center. We are proud to have the Lewis Kaplan Stroke Service at University of Maryland, since Dr. Kaplan was a graduate of University of Maryland Medical School. And so thank you for your attention, and I'll be happy to address some questions later in the presentation.
Thanks for the talk, Professor Chaturvedi. Now let's move to the second talk by Professor Marc Chimowitz from Medical University of South Carolina in Charleston. He has led 3 large consecutive NIH NINDS-funded multi-center clinical studies over the past 20 years for preventing stroke in patients with intracranial stenosis. He will talk us through the management of stroke with both intracranial stenosis with atrial fibrillation. Professor Chimowitz, please.
Good morning, good afternoon, good evening to everyone, and thank you as well to the World Stroke Organization for asking to give this presentation on the management of stroke with potentially both intracranial atherosclerosis and atrial fibrillation mechanisms. Seemant gave a really nice talk that included a lot of the epidemiology, which is fairly similar with intracranial athero. I'm going to focus my talk on the challenges of antithrombotic therapy. So this is my disclosures. My grant funding has been from the NIH, and I have had industry support in the form of providing medications and devices for the clinical trials that I've led. So intracranial atherosclerosis is a very important cause of stroke worldwide, especially prevalent in Asians, Blacks, and Hispanics. And based on the ethnic and racial makeup of the world population, some have argued that it might be the most common cause of stroke worldwide. and it has a particularly high risk of recurrent stroke. So in the WSO trial that our group led, we compared warfarin with a target INR of 2 to 3 versus aspirin, very high dose aspirin of 1,300 milligrams a day. This was a trial done some time ago. And these are in patients with 50 to 99% intracranial stenosis who'd had a TIA stroke within the last 90 days. And you can see that warfarin and aspirin were essentially equivalently efficacious in the study, and the primary event rate of stroke and death occurred in about 22% of patients at 2 years. So it's a high-risk condition. And moreover, if you look at the patients in WSO who had 70 to 99% stenosis, whose qualifying event was within 30 days, the 1-year risk of stroke in the territory was almost 23%. So it's a very high-risk condition. And we know from the Sampras trial that actually compared stenting plus aggressive medical management versus aggressive medical management alone, which consisted of aspirin and Plavix, clopidogrel for 90 days, plus intensive risk factor management in both arms, and followed by aspirin just alone after 90 days. That's medical therapy was significantly better than stenting, largely because of the increased peri-procedural risk of stenting, but even beyond the 30-day peri-procedural period, the event rates were the same in both arms, so the curves never approached each other. One of the reasons that Sampras showed a benefit was not only because the stenting arm risk was higher, but the medical arm risk was lower than what we had projected based on the WSO trial. This is what we projected would be the medical event rate in Sampras based on the data from WSO, where patients were treated, as I said, with either aspirin or warfarin and just routine risk factor management versus the actual rate in the medical arm in Sampras on aspirin and clopidogrel for 90 days, followed by aspirin alone and intensive risk factor management. And you can see the risk was about half of what we projected. And we think this is because of two reasons. One is because of the more intensive risk factor management, which is probably responsible for the fewer events later on beyond 90 days. But even within the first 90 days, you can see a separation of these curves. And I suspect that much of that has to do with the combination of aspirin and clopidogrel. So the current recommendations, which are being updated and should be coming out this year, but the current recommendations do suggest that adding clopidogrel to aspirin might be reasonable. And if you look at point and chance, even in patients without intracranial athero, that seems to be a reasonable thing to do, at least for 30 days. And because of Sampras, we use it in 90 days. Most people are using it for at least 90 days. In fact, in the United States, about half stroke neurologists are using clopidogrel and aspirin beyond 90 days. And the guidelines also recommend that stenting should not be performed in these patients. Now, if we turn to atrial fibrillation for the moment, what do we do for those patients? Well, unless you have a CHA2DS2 2 score of 0.1, you're basically using anticoagulation. And if you've had a stroke, you by definition are already at a 2 for the CHA2DS2 score that would require you to be on anticoagulation. So then the question is what should be the antithrombotic treatment in a patient who has stroke, who has intracranial atherosclerosis as well as atrial fibrillation? And it's a challenging question. So your choices are really, no one's really considering single antiplatelet therapy for either of those diseases, AFib or intracranial athero. So your choices are dual antiplatelet treatment, anticoagulation alone, and if so, which one? Or should you combine anticoagulants and antiplatelet treatment? So, I mean, dual antiplatelet treatment is currently what's being used for intracranial athero, but is there any evidence that it works for atrial fibrillation? Well, for those of you who've been in the field for as long as I have, you'll remember some older studies, and one of those was the active, well, two trials, the active A and active W trials. These were trials that compared clopidogrel plus aspirin versus aspirin alone in patients who were considered to have a contraindication to warfarin. That was active A. And then active W compared clopidogrel and aspirin to anticoagulation in patients who did not have a contraindication. And it does turn out that clopidogrel plus aspirin is more effective than aspirin alone for preventing ischemic stroke. But the risk of major bleeding with the combination was 2% a year compared to 1.3% on aspirin, and intracranial 0.4 versus 0.2, both significant. So the ischemic benefits are there, but the hemorrhage risk is higher. And then if you compare head-to-head clopidogrel and aspirin to anticoagulation, anticoagulation was much better for preventing stroke. And the major hemorrhage rates were no different on clopidogrel and aspirin than on oral anticoagulation. So you'd have to ask yourself, if you have a contraindication to oral anticoagulation therapy, you probably have a contraindication to using clopidogrel and aspirin as well, because the hemorrhage rates are similar on these two approaches. So it's not a great therapy for atrial fibrillation, the combination of clopidogrel and aspirin, whilst it might be the better therapy for, it might be an acceptable therapy for intracranial stenosis, or it is an acceptable therapy. What about anticoagulation alone? Well, I showed you this earlier, where warfarin appeared to be equivalent to aspirin, but it's important to recognize that in a post-hoc analysis from WSO, and this was actually in the original paper, if you looked at the event rates in the warfarin arm based on their INR specific rates, and you could maintain an INR between the target rate of 2 to 3, the ischemic stroke rate was much lower than if it was lower than 2. And so this rate is much lower than the aspirin rate in WSO, suggesting that anticoagulation does work for intracranial stenosis. The challenge, however, is maintaining an INR between 2 and 3, and we could only do that about 65% of the time in WSO. It's also important to note that the intracerebral hemorrhage rate on warfarin alone in WSO, there were only 2 hemorrhages in the study, ICHs in the study, out of about 286 patients. And so the ICH rate was 0.4 per 100 patient years of follow-up, which is not that much higher than I just showed you on clopidogrel and aspirin in the active A study. So that's a consideration, warfarin alone. And now we have the potential advantage of NOACs, and NOACs have a persistent anticoagulation effect even at the trough plasma level. So they offer a potential advantage over warfarin, where you have to maintain this target INR so carefully. Unfortunately, though, there's no data on NOACs for intracranial stenosis, or very limited data. So what about combining anticoagulation and antiplatelet treatment? Well, the problem there is that there's a higher risk of intracerebral hemorrhage. And this is an old paper from Bob Hartz and colleagues that showed that the relative risk of an intracerebral hemorrhage when you add aspirin to anticoagulation, to warfarin, is 2.4. So if you double the risk that we showed of 0.4%, 0.44 over 100 patient years, you're now talking about 1%, at least 1% per 100 patient years of follow-up if you added aspirin to anticoagulation for intracranial stenosis. That's the rough estimate. And so what do the guidelines say about using the combination of oral anticoagulation with well, they don't recommend it for patients with ischemic stroke, but they say it's reasonable in patients with clinically apparent coronary disease, particularly in acute coronary syndrome or stent placement. And if you look at trials, and here's one of the trials, the REDO PCI trial, where they've used dual antithrombotic therapy after PCI in patients with atrial fibrillation. Here, patients were given dabigatran at 110 plus, mostly clopidogrel, although a few patients got ticagrelor. And you can see the major hemorrhage rate during a mean follow-up of 14 months was 5%, and the intracerebral hemorrhage rate was 0.3. Now remember, these on patients that have not had stroke, and I'll show you in a moment that once you've had a stroke, your risk of an intracerebral hemorrhage is much higher than if you haven't had a stroke. But they do suggest, and here's the triple therapy data with warfarin, clopidogrel, and aspirin, and there you can see that the major hemorrhage rate really goes up to very high numbers, 9.2 for major bleeding and 1% over 14 months for intracerebral hemorrhage. And again, remember, these are not stroke patients. Once you add stroke to the mix, you're dealing with higher rates. And here's the data from COMPASS, which was low-dose rivaroxaban and aspirin versus moderate-dose rivaroxaban alone versus aspirin in the patients in that trial who had stable coronary disease and peripheral vascular disease who had a prior stroke. And you can see the annual rate of intracerebral hemorrhage, while it's not very high in patients who'd had a stroke more than 30 days ago, was still 3 times higher than patients without a stroke, illustrating that if you've had a stroke and you're put on antithrombotic therapy, your risk of having an intracerebral hemorrhage is 3 times as high. So if we go back to this data and we assume that if you'd had a stroke and you triple this number, you're talking about hemorrhage rates that are in the 1% range, which is the same kind of range I showed you with, if you look at adding aspirin to warfarin in WSO, if you make those calculations, it's about 1% per year or per 100 patient years of follow-up. And so we worry about hemorrhage a lot in stroke treatment, but sometimes I think, in my view, we ignore the ischemic side of things. And remember that the stroke risk with ICAS is much higher than the recurrent hemorrhage rate, even on anticoagulation. Here's an example. When we use the new American Heart Association endpoint definition for stroke in SAMPRAS, that is, any infarct, any symptomatic infarct on imaging counts as a stroke, then the stroke rate on aspirin and clopidogrel for 90 days followed by aspirin alone and intensive risk factor management in the medical arm was still 21% at 1 year. So you're comparing rates of 21% on the ischemic side versus, intracerebral hemorrhage rates of, 1% even in combination therapy on the hemorrhage side. And so I think we've always got to keep this perspective of what the disease we're dealing with. In my view, ICAS deserves an equivalent status to acute coronary syndromes or PCI in recommending antithrombotic therapy. So the question you have to ask is, would low-dose NOAC and aspirin be the ideal treatment for these patients? And here's data from COMPASS where they looked at the stroke subtypes in COMPASS, and you can see that when they use the TOS criteria for defining strokes, the large artery people here are all carotid disease. The intracranial people, I think, are tied up in the ESUS patients. But you can see that the combination of low-dose rivaroxaban plus aspirin was actually, looked like it was effective against all subtypes of stroke, especially including atrial fibrillation cardioembolic strokes and the ESUS strokes. So there is a suggestion from COMPASS that low-dose rivaroxaban and aspirin works well for preventing stroke and potentially of all subtypes. That's on the positive side for combining the combination. But for those of you who've been in the field for as long as I have, you'll remember SPAF3, which compared warfarin with adjusted dose to target INR of 2 to 3 versus a fixed dose, low dose of warfarin. They were trying to target an INR of about a 1.2 to 1.5, and once they had got there, they left it there, and they added aspirin. And you can see that that combination was nowhere nearly as effective as warfarin alone for preventing a stroke or systemic emboli. And the hemorrhage risk was again almost double. He has this 1% number again when you combine warfarin with aspirin. So over a mean follow-up of 1.1 years. So adding aspirin to low-dose warfarin is not as effective as using warfarin alone in patients with atrial fibrillation. Well, whether that's true of low-dose NOAC and aspirin, we don't know at this point. So before I show you my final slide on my recommendations in future, I do think there's some important clinical questions you should try to answer on deciding the best treatment in each patient. The first one seems pretty obvious, but is the stroke in the territory of the stenotic artery? That's very important, because if the stroke is not in the territory, you're dealing with asymptomatic ICAS plus atrial fibrillation. And asymptomatic ICAS has a pretty small risk of stroke. We showed that in the WSO data for people that were identified as having a contralateral stenosis. And in other studies, they've also shown a low risk of stroke. So those patients, you can just ignore the intracranial atherosclerosis, in my view, and just treat them for whatever you, with a NOAC for their atrial fibrillation. And then even if you have a patient who has stroke in the territory, is that stenosis from atherosclerosis and not a recanalized embolus? And there are a couple of things that you can do to try to figure that out. You can do serial transcranial Dopplers and see if the artery recanalizes. And you can use high resolution MRI to see if you can see atherosclerosis in the arterial wall. Those are things that you can use to help you. The other thing to think about is the infarct subcortical and less than 1.5 centimeters? In other words, is it in the perforated territory and unlikely to be an embolus from atrial fibrillation? You know, the CHADS-2 VAS score counts any stroke as part of the score and gives it a score of 2. But I've always assumed that they were thinking about that being a stroke related to atrial fibrillation. If you have a perforated stroke, I'm not so sure that you should give the same value as 2 to the stroke. So maybe if you had a patient who had a perforated stroke, who had no other risk factors to give them a higher CHADS-VAS score, and they only had a CHADS-VAS score of 1, you might not think about anticoagulation in that particular situation. And then you can use MRIs if they have a lot of microbleeds that might persuade you one way or the other not to use or to use anticoagulation. And then obviously, Seemant's already spoken about the CHADS-2 VAS score and the HAS-BLED scores to help you. So these are all clinical features that you can use to try to help you decide. So my take-home messages and future directions for research: the optimal antithrombotic therapy in patients with coexistent mechanisms is uncertain. My personal choice is currently anticoagulation alone, though an argument could be made for using anticoagulation plus low-dose aspirin, because ICAS is such a high-risk condition for recurrent stroke. I think separate trials are needed to evaluate the efficacy and safety of low-dose NOAC and aspirin in patients with ICAS, and a separate trial in patients with atrial fibrillated stroke. If both of those trials are positive for low-dose NOAC and ICAS, then that would be an ideal treatment for patients with coexistent ICAS and atrial fibrillation. Thank you very much.
Thank you for the talk, Professor Chimowitz. Okay, now let's start the Q&A session. So there's a question here. So most of the cardiology trials looking at DOAC and the antiplatelet are only for 1 year. So what are both of you maybe suggest for the long term, like after this 1 year?
Yeah, no, that's an interesting observation. And it is true that most of them focus on a relatively short period of time after the acute coronary syndrome. And so I think after 1 year, you could see, for example, if the patient is on a DOAC plus low-dose aspirin or DOAC plus clopidogrel, you could see how they're tolerating that regimen in terms of bruising or bleeding, and also what their risk factor profile is. If they're tolerating it, you could make an argument for longer-term treatment. If they're having issues, then maybe you could drop the antiplatelet agent and go with anticoagulation alone. And yeah, so I think that that's another area which is ripe for future investigation.
Yeah, so adding to that, the risk of stroke in ICAS after a year is very, very low. The WSO and Sampras trials show that once you get to a year, the curve, the Kaplan-Meier curves really plateau. And so I would strongly recommend, without data at this point, that as such a patient who had both mechanisms, I would just use anticoagulation alone and not the aspirin, because I think the hemorrhage risk then starts exceeding the recurrent ischemic stroke risk at that point.
Okay, I think it's summarized well. And now the next question is, so I think we only have the evidence from maybe COMPASS to say the anticoagulant we choose now is rivaroxaban. But do you have any preference or experience that which type of the NOAC would you choose for the patients with both carotid stenosis and atrial fibrillation outside the trial? I guess that's what he means.
Yeah, I think if you look at the cardiology studies, there's some evidence that each of the major DOACs has some utility. And for example, apixaban was looked at in the Augustus trial. And then Dr. Chimowitz spoke about the dabigatran trial. And then there's the data for rivaroxaban. So I think each of those has some evidence in its favor. And I think the clinicians should use whatever agent they're comfortable with and whichever data set they're comfortable with.
I mean, I agree with that. The only argument that I could make there is that, for the combination therapy in secondary prevention of stroke, the only one that's been studied so far is rivaroxaban and aspirin. It's the only one that's FDA approved. So that's just one consideration that you're taking into account, which one is FDA approved. But other than that, I agree with Seemant.
Okay, now we have another questions regarding the NOAC choice. So the latest elder care AF trial used reduced dose endoxifen 15 milligram in elder patients who are older than 80 years old with high risk of bleeding. So one of their main inclusion criteria is co-contaminant of antiplatelet use. So do you favor this approach of using low dose endoxifen in such patient subgroup? For example, if they also have carotid stenosis or ICAS?
Yeah, that's an excellent question. And I was actually wondering whether somebody would bring that study up, because I think that was a provocative study. And I think for the elderly, especially once you're getting above age 80, above age 85, we do worry a lot about both systemic bleeding and intracranial bleeding. And so I think that's where there's probably a stronger role for low dose anticoagulants. And so in that particular study, yeah, they were primarily looking at patients without recent stroke. And so we can't really extrapolate entirely to patients with recent stroke. But I think if you use either the COMPASS regimen or the elder care study regimen in the elderly group of patients who need antiplatelet therapy, that's probably a good rationale for using low dose anticoagulation. But at the same time, I would say that we need some more randomized trial data. And so Dr. Chimowitz had mentioned that that there could be a future study looking at low dose anticoagulation plus antiplatelet therapy. And so that might be a good group to carry out such a study.
Yeah, before we kind of jump on the low dose anticoagulation and aspirin bandwagon for these patients, remember the SPAF3 results. That trial showed that low dose warfarin and aspirin was not nearly as effective as regular dose anticoagulation, which is the reason why my personal preference right now, without data established yet on the combination, is just to use anticoagulation alone, because there we have clear evidence of benefit for atrial fibrillation, And we have a strong suggestion from WASID that if you can control the INR between 2 and 3 and maybe use a NOAC instead of warfarin where you have less of a problem with that agent is effective for ICAS too. That's the reason I prefer at this point, without any other data, to use anticoagulation alone. But I do think that I have hope for the combination of a NOAC with a low dose NOAC and aspirin, but we don't have the data yet the definitive data yet for that.
Okay, so now let's see another group of people who have valvular atrial fibrillation plus atherosclerosis. Would you ever encounter people like that using warfarin plus antiplatelet or some other kind of the combination?
I think my answer is the same. I would use just anticoagulation alone in those patients. I mean, valvular AFib is clearly indicated for warfarin for sure, and I think NOACs haven't been studied in that population. But adding, I'm not so sure there's proof yet that adding an antiplatelet agent is the right way to go. I mean, I would have liked, I guess we also have to remember that there are trials that have shown that warfarin is just as effective as aspirin for secondary MI prevention. So the WARIS trials were done, which compared warfarin with aspirin and showed that warfarin was at least as good as aspirin for secondary MI prevention. And I know it's hard to persuade cardiologists to not use aspirin, but in fact, in my view, they ignore data from randomized trials that actually show that warfarin is just as good as aspirin for secondary MI prevention. So that's something else to keep in mind. Now for PCI, that's a different story because there the benefits of antiplatelet therapy have been established. But in secondary prevention after MI, warfarin is an effective therapy.
Professor Chaturvedi, do you want to add on anything on that?
No, I basically agree that I think for patients with valvular AFib plus atherosclerotic disease, yeah, you could make an argument for either anticoagulant warfarin alone or warfarin plus low-dose aspirin.
Okay, thank you. So now we have a question about the localization. So does the localization of the stenosis play a role? For example, maybe high-grade basilar or like MCA or carotid, they differ from the medication you choose?
I don't think it makes a difference. You know, I think that both, contrary to kind of long-standing belief that patients with vertebrobasilar disease have a worse prognosis than patients with anterior circulation intracranial stenosis, we found the opposite in Sampras, that patients in the anterior circulation on medical therapy had a worse prognosis than the vertebrobasilar patients. So I don't think that vertebrobasilar disease warrants a different therapy to intracranial anterior circulation disease.
Yeah, I agree for the intracranial lesions. For extracranial carotid disease, yeah, we don't have sort of the same data regarding 90 days of dual antiplatelet therapy, although some clinicians have extrapolated from Sampras and have started using 90 days of dual antiplatelet therapy for patients with moderate to severe carotid atherosclerosis. And yeah, but I don't think we have any conclusive information that the location, like whether it's MCA stenosis or basilar, makes a difference.
Yeah. Okay, here's a question for Dr. Chimowitz. So do you think there's a role for DOAC alone as a secondary prevention in intracranial stenosis in patients without AFib?
So that's a great question. Unfortunately, I don't have any data to provide wisdom on that. You know, one would think that it would be as effective as warfarin. But unfortunately, we just don't have the data to show that. It's kind of like the data for, preventing stroke after transmural MI. The data that's available is on warfarin and not so much on NOAC. So the question really is there pharmacology that would indicate that the NOAC might be better when you've got stasis of blood in a left atrium, whereas maybe in a more faster flowing arterial stenosis, it might behave differently? I don't think so, but until the studies are done, I can't really say that you should be using a NOAC instead of warfarin. The only data we have on intracranial stenosis, the most reliable data we have on intracranial stenosis with anticoagulation is from WSO, and that use warfarin. So I personally don't use a NOAC alone for intracranial athero at this point.
Yeah, fair enough. Okay, so next questions. So what to do if a person with AFib gets an ischemic stroke while already on factor 10 inhibitors? I guess there's some more general questions. Well, recurrent stroke, like already for someone already on DOAC.
Yeah, I think there are several things you should analyze. Number one is, as Mark was commenting earlier, what is the nature of the stroke? Does it appear embolic, or is it more of a perforator stroke? We know from plenty of 20 years of HFib studies that the patients with the lacunar strokes were not really differentially affected by anticoagulants compared to antiplatelet agents. And so if you are convinced that it was an embolic stroke, then I would also investigate the patient's compliance in terms of any missed doses. And if you're convinced that the stroke occurred despite full compliance, there is not a wealth of data on switching from one agent to another, but you either could switch from one DOAC to another, or you could add an antiplatelet agent. And then once again, there's not that much evidence that if the patient fails a 10A inhibitor, would you shift to warfarin? The trials would probably suggest that that's not that valuable. So I would look at some of those issues, especially compliance.
Yeah, I don't have anything to add. I agree with Seemant.
Okay, so I think that's all for our questions. So thank you for all the talk. It's very interesting and inspiring. Thank you both all. And thank you for all the attendees today to join our webinar today. So I'll hand back to Alina, who will wrap up today's talk.
Yes, thank you. So all that's left for me to say is basically thank you to the speakers, thank you to our moderator. And one last thing I'd like to do is announce our next webinar, which is next Friday. We are very excited to have with us Professor Suwanwela from Thailand, Professor Caso from Italy, and Professor Baring from the UK. And they're going to discuss the topic, timing of starting anticoagulation in ischemic stroke with AF. And that's going to be at 11 a.m. CET. As mentioned before, there will be a recorded version of this webinar. You'll find it on the WSO homepage following this link. And if you're on Twitter, you can follow all our updates there at worldstroke.org and at worldstroke.ed. So thank you very much. Have a nice day and hopefully see you next time. Bye.
Thank you.
Bye.
Bye.